This is going to be a general introduction and breakdown of the care and management of your non-emergent ventilated patients that you're going to be coming across on the floor. This is going to be your CPAP patients, your BiPAP patients, your mechanically ventilated trach vents that have already been long established, we're not in further state of decline, relatively stable, coming in for either weaning, for small titrations, or just moving down, have already been here for a while and are getting ready to discharge. And these are the pretty much most common vents we're going to be seeing on the floor. Alright, so these are going to be the two most common vents we're going to have when patients come into the hospital. We have our Trilogy. This one's a T200. They come in lots of different models, doesn't matter, they're all pretty much function the same. Moving on for Trilogy, this here is an Astral. This is going to be one of our new vents that we're going to start seeing more of, and we're going to start seeing a lot of patients transitioning off Trilogies onto this one. This is pretty much where we bleed in oxygen on both vents. They have a nipple on the back, connects to O2 tubing that comes off the wall. And we're going to go over pretty much how easy it is to go up on the FiO2 on any of these vents, because that's pretty much the first thing that's going to happen that we're going to need to do non-emergently in pretty much all ventilated patient care. If for any reason we have a patient and they don't come in with a piece of their equipment like heater wires or heater tubing or their heater itself, by default, if they're missing any piece of equipment, they have to go on one of our vents. A patient going on one of our servo does not mean they're automatically getting escalated in care. They can go in the exact same settings they were on one of these vents. It just means they forgot something and they have to go on our machine, which is fully assembled by default. It's no more intense than these two vents. The care is exactly the same. So if we have a patient on a servo, which is our vent, and we need to adjust the FiO2 for any reason, there's a knob right in the bottom, right under the words O2 concentration, that directly goes up on their FiO2. So you can take it from 50, right at 60 it'll usually ding on you, let you know that you're going on some high FiO2, and then it'll allow you to continue as high as we need to, up to 100, or back down again. And it always dings at 60 to let you know we're going from high to low FiO2, back down all the way up to room air. Fairly simple. On both of our home vents here, the Trilogy and the Astral, you connect oxygen tubing directly to the back of the vent through this nipple. On both vents, if you need to go up on the FiO2, it is simple as taking the flow meter, which would have your oxygen tubing attached to the vent, and dialing up the flow. Alright, now that we've gone over how to adjust our FiO2 on our vents, it's time to go over basic troubleshooting of a kid on a home vent. First and foremost, you walk outside a room, you hear a ventilator alarming, you walk into the room, the first thing you should do is look at the child and determine, is your child stable? If your child is stable, then we can go ahead and further discuss small troubleshooting of the vent and how to find out why you're alarming. If your child is not stable, the first thing you should do is take your child off and start bagging and call for help. Okay, so we've walked into a room and we've determined our patient is stable, so we're going to try going over some of the alarms we're going to see. Probably one of the first alarms we're going to go over is your high pressure alarm. Regardless of which vent the high pressure alarm is going off in, we're going to troubleshoot the same way and take the same, approach to clearing the alarm and finding out what's causing it. First off, we're going to look for coughing, increased secretions, bronchospasm. Is there anything obstructing the airway? Water sloshing inside the tubing? Blocked pressure lines? Or possibly a partially occluded ventilator circuit? If it isn't cruddy, something on the end of it, just any reason that it would cause the pressure to go up. We would troubleshoot that. We would look at the patient. We would suction, try to clear secretions. For trach patients, if we can't pass the suction catheter, your first thing would be to go ahead and remove the trach and replace it. If there's not a trach in place and there's not an obvious obstruction, there's always bagging the patient and calling RT. The next alarm, we're going to go over our low pressure alarms. So what we're going to look for are leaks in the circuit, leaks around the trach, loose trach ties, disconnected circuits, change in the overall patient condition. Let's see, positional leaks. Do we suddenly go to the left side or right side? Jostle the trach a little bit. Make sure the trach is actually in. We didn't decannulate in the big change or move. If the patient's cuff is still inflated, if there isn't a leak around the cuff. If we're on BiPAP or CPAP, did the patient move their head? Is there a large leak around the interface, around the mask? And is the suction catheter pulled back too far and we're losing air in the inline suction catheter? Really easy to look forward. And of course, to troubleshoot that, we would reposition the vent circuit, make sure there's not any leaks on it. If we're on CPAP, BiPAP, we would reposition the mask and try to make sure there's not any leaks going around the face. We would verify the cuff pressure if we're a trach patient. We would check trach position, make sure we're midline and not pulling to any side. You would definitely check your suction catheter to make sure that you didn't just pull the catheter too far out of the ballard. And then again, check all the vent circuit fittings to make sure that we're not losing air anywhere. Another alarm we would look for is apnea. First and foremost, we're going to make sure your patient is still breathing at a decent rate. We would look for upper airway obstruction. Again, things plug inside the trach. We would check for a change in patient status. Again, are they still breathing? Are they able to trigger correctly? And finally, we would check and make sure your apnea time, is it appropriate? Is it too long or too short? Of course, we would reassess your patient. You would check your settings and make sure your alarms are okay. And if we're still having apnea alerts, you would definitely call your RT. Next, we would look for a low battery alarm would be the next one. Pretty obvious. If you're having a low battery alarm, you would check and make sure your ventilator is actually plugged in. If we have a low battery alarm, that one's a very easy one to fix. Next alarm we're going to go over is high respiratory rate. We would look and find out, is your patient anxious? Are they worked up? Are they fussy? Are we having increased work of breathing because we're in any kind of distress? Is there water sloshing inside the tubing that's causing a double trigger? Or is their sensitivity their trigger sensitivity too high? We would check your patient's pain level. If they're in pain, pain meds are easy to give. If they're being fussy, you can get their parent or someone to help them be calm or try to calm the patient. Let's see, if the patient is distressed to increase work of breathing, we tried suctioning, definitely call the RT. Another alarm to go over is the low circuit leak alarm. That one we'll usually find on our home vents, our Trilogy and our Astral. And you will normally see this on any vent that has a single limb circuit. Now, all of these vents on single limbs have a whisper valve that allows your patient to breathe out. It allows gas to escape and air to escape from here. If this is covered in any way, your patient's not going to be able to exhale and your ventilator is going to alarm. So, when checking this, you would make sure that there's not any sort of crystallization from nebs, if we're running nebs through the line. Nothing's just flat out covering the whisper valve itself. We don't have blankets over it, tape, anything that could be occluding the ports on it that allow the air to escape. And if it is completely open and still showing a low leak, just call your RT. Lastly, we can go over low sats. If your patient has a low sat alarm, we're going to check if the airway is in place and still patent. We're going to check for coughing and secretions. And seems silly, we're also going to check and make sure your O2 tubing is actually plugged into the vent and the wall. More often than not, it's very simple. The tubing just popped off and all of a sudden we're having a desat because we're not getting any oxygen. Easy fix for that would be to plug it back in and see if our sats don't go up. Alrighty, so I've already gone over most of the small alarms and some of the troubleshooting steps we can take to take care of most of the minor situations that will arise taking care of a ventilated patient. There are times, however, that you're going to want your RT at bedside immediately. First and foremost, if your patient has a severe deterioration in clinical status, you're going to want your RT at bedside. If for any reason you have to take your patient off and bag them, you definitely want your RT at bedside. If you've done any of your troubleshooting steps thus far and nothing is working, you want your RT at bedside. And if your trach has come out and needs to be replaced, you want your RT at bedside. Other than that, if you perform any of your troubleshooting steps and make any minor changes and everything resolves, you should definitely let your RT know and give them a call, but it might not be important for them to be at bedside at that time.